Good afternoon once again, and I thank all the panelists for doing a wonderful job. I'm very proud of them that they have not, hypothesized or conjectured or did some extrapolation in terms of interpretation of the law. But ladies and gentlemen, from our perspective, serving as a president of the largest fundamental society in the United States last year, and being in the throes of discussion, not once, twice, but probably more than 100 times, here's my feeling for certain individual, then as a physician, and as a fellow Texan. I think, we have been discussing about healthcare reform in this country for a long time. Failure is not an option. At the end of the day, we're Americans. We know how to pick our battles. We know how to win. I think we have to come this day, and time has come for us to really put this in the right perspective and see if we can win this battle. There can never be a great winning without beginning. So I certainly feel that we want to win on this, and it's a great beginning. And there'll be, there'll be a lot of changes and amendments as we with coming times. So certainly it's going to induce a tectonic shift from the perspective of physicians who practice medicine in this country, from the perspective of consumers who are anticipated, from the perspective of industry and the hospitals and whatnot. This shift is going to incorporate German discussion change. At the end of the day, we are here at this point in time again that we emphasize that this reform is to stay. Probably it's going to be modified with time. We're all bracing ourselves for the immediate future to change our ways to practice medicine. It is not fun for us to repeatedly hear across the world that as a great nation like America, we have millions of people uninsured. We have 36 in the world rankings in terms of quality of care. We have one of the highest infant mortality rates of the developed nation. On and on and on and on. Time has come up for us to basically listen, dissect this, put the partisan behavior and self-interest behind and see what best can be done. And this for doing justice this afternoon, if you think they're not interested to incorporate. At the end of the day, what we're trying to do with this reform is that reduce the cost of care and improve the quality of care. For the second perspective, we reduce the cost of care by essentially saying that do not incorporate services which are not required, for the patients unnecessarily. And that's where this whole issue of prevention comes into play. I think the preventive services, the mandate to preventive services with copay, I believe are going to really make an enormous difference with time in the next decade or so, to keeping the population healthy and thereafter reducing, certainly the cost burden. The second issue with regards to improving quality of service, physicians have now several regulations. Some of them are good, and some of them will be arguing with the federal government to see if they can change with time. The great things are to bring the primary care providers together at the end of the day and see if you can incentivize them. There will be 34% increase in the remuneration for primary care doctors, 50% of practitioners, internists, and pediatricians across the state, across the country for their E&M services, which is for their consultative services. And beyond that, there will be a 10% incentive for primary care doctors, those of them who bill their Medicaid charges, more than 60% from all patients visiting nursing home facilities and some of the other visits. Even general surgeons have incorporated this broad plan for a 10% incentive if they operate in the underserved areas. So things of this nature have been built into where doctors can look into, come together and see if they can reduce, they can improve quality, and also make sure that they are reimbursed for the services. So on and on. I think there are certain good things. What we don't like from the physician's perspective in the healthcare plan right now, which needs to be addressed mostly, is that there is this IAPAC, independent physician, independent payment advisory panel, which the government has constituted in the Affordable Health Care Act. This panel will be 15 members will vote on this panel, and they will be in control of setting up the Medicaid rates. This is what the physician community does not like. At this point in time, we do not want an independent nominated member to not happen to control the disbursement or to control the ratings and fixing the Medicare prices, rather Congress do it with good deliberations and whatnot. That is one major thing. The second thing we want to incorporate is Texas has really fought valiantly with regards to its medical court reform, allowed reform 2003. And Texas is the #1 state across the country to limit 23,000 new doctors amended from 2003 to 2012 to practice here, particularly for those specialties like neurosurgery, pediatric obstetrics, where once upon a time, just about 7 or 8 years ago, we saw doctors fleeing the state of Texas. So we do not want our liability reform, the way in which that we have written, to be voted on the national liability reform at the end of the day and lose perspective on that. So there are a few things I think this healthcare reform should address with time. We want to keep several of the things that are in place, and a few things that which are broken, they need to be fixed, and that's the central message. Given that I'm open, for the next 15-20 minutes to the audience, if you have any questions, I would like please go ahead and raise your hands, and then I will address the panel. This really works in the context of healthcare. There's cases such as non-covered patients, so people have dysfunctional services or very concerned. And it's works because it works in the case of endo surgeries, cases surgery or very poor shop around,
that the supply and demand may not really work. Because I come from India and I have spent my first 23 years in India. I know the kind of healthcare in India. It's very, if you look at it last month, there was a child died because they couldn't pay $3.50, 200 rupees they were not able to pay for some kind of medication. So it really, I think we shouldn't really go down to the lowest common denominator, but we just have to find out if supply and demand have to really work, we probably have to take the insurance out of the system. But I don't think that will be possible. So we have to find out what are the real options available.
Let me just address some of those issues. There's different types of healthcare. I mean, what you've described, being in an accident, that's a catastrophic coverage. Okay, most of us on the supply side or the consumer side, market-based practitioners feel that it's the responsibility of governments to make sure that there's a floor that covers those patients in catastrophic situations. Currently, the system in the United States is through the EMTALA mechanisms where the patients go to the emergency room and have to be treated if they can pay or not for those types of emergent things. Then after that, there's elective care. Let me tell you very briefly what happened to me last week. I was in my clinic seeing my follow-up patients. I had 5 patients in a row. The first 4 were breast cancer patients. All of them I treated with radiation. Excellent women. All of them had Cadillac plans. Many of them from United Healthcare, actually. All in the petroleum business. Every single one of them came in and asked for a PET scan. PET scan is a very expensive procedure that costs $5,000. Not one of them needed it. Okay, it took me 10 minutes to sit down and explain to the patient they just didn't need this test. Wasn't going to address any issues. Okay, now I can't go to them and give them an economics discussion like we had here. They'd walk out the door. American doctors aren't supposed to talk like that. Okay, the 5th patient came in and I'm looking at his chart. First of all, he has Hodgkin's disease. Secondly, he needs a PET scan. Thirdly, he didn't ask for the PET scan. As I'm looking through his chart, I see that he got a CT scan in Huntsville, a prior PET scan in Sugar Land. He had a chest x-ray in the middle of Houston. And I'm saying, how the hell did he end up with all of these different tests? This is a man who didn't have health insurance. He was paying for it from his own pocket. He picked up the phone and called each and every one of those facilities and actually negotiated the lowest possible rate. He acted like a rational consumer, okay? And he didn't ask for a PET scan. Now, if I went to him and said, you need a PET scan, which I did, he'd get it, and he did, okay? So that's an example of how the market can work in healthcare. Now look, I'm not saying that it's totally market, but you have to have some market in there. In China, insurance pays 50% of the cost, 50%. The other 50% is the consumer. At least the consumer is looking at the bills. Okay, we have an enormous problem in this country with Medicare and Medicaid fraud. What about if we empowered our senior citizens to keep some of their Medicare monies if they actually looked out for fraud? That would be pay for itself in spades. We can split it with them. So don't totally divorce yourself from the market, because when you do that, you lose access. Okay, and that's the issue. Do we want to be a wealthy country? Do we want to work hard? Do we want to have the money? But when we get to be 75, do we want the IAPAC, which doesn't necessarily decide rates, it also decides what procedures you can do? Okay, do you want the IAPAC to say, you will not get a hip replacement? Because in order to balance the books and pay for vaccines for children, you need to walk with a cane. Okay, do we really want that as a society? The Canadians can come to the United States. The only place we can go to is India. You know,
But this is the thing. This is the thing, you know. I do not like this kind of conversation because I don't think that's what the debate is about. Market versus non-market. This health insurance bill is all about keeping the market, improving upon the market. It first of all starts with the admission that in our individual health insurance market, we have no market. It's a broken market, and we are not trying to replace it with government. We're trying to replace it with something that might work as an efficient market. That's the health insurance exchanges. That's what we're trying to do. Dr. Behar, you know, the either-or, market is good or bad, government is good or bad, is not going to be a constructive line of argument here. We have to look at the specific proposals and what they're trying to do in terms of building on the existing market forces, or where the market forces simply cannot work, substituting a government a program that will.
So, Dr. Begley, I think
I
think you hit the nail on the head, and one of the important things we missed this afternoon to further expound on is a question addressed to Mr. Rogers here from the insurance standpoint. The fact that the government wants to create these insurance exchanges across, in every state. The purpose of the insurance exchanges are, we have more than 1,000 different insurance companies. Let them participate in the exchanges, and they are stipulated, really, the rules and regs for this exchange. In the sense, if you're an insurance company, you have to essentially post, just like you buy a cereal package or a Campbell soup. You have all the ingredients on that. So the government has stipulated, as an insurance company on the exchange, you have to completely catalog everything that you're going to provide for the premium that you're charging. It is a postulation by the drafters of this act that creation of such an exchange, when several companies compete, the premiums will automatically decrease because they'll be vying for populations to get insured under their respective insurance company. So I'd like for you to address, I know the state of Texas is different, the governor has a different stand, which is fine, but as a nation as a whole, what are the merits of these exchanges from the insurance perspective? And one other thing that we also know, that insurance companies will be regulated. They have to report the med-loss ratio, which is essentially what it means. The ML ratio is that 80% of your premium has to be spent on your care, and only 20% for administrative expenses. This is completely mandated. There's no confusion there. If they save the money, they have to return that, just like we get our checks from auto companies, whatnot, to the insurers. So please comment on these two things.
Thank you, Dr. Ray. The exchanges are going to be set up as a portal or a place of access for everyone to go and get their insurance. You're able to get the insurance now, but the exchanges are going to make it easier. They are going to introduce what's called a navigator, and the navigator is going to direct you to which insurance company should be the best one for you. But I do want to go on the record and say that currently we have agents and brokers that are well versed, and they're able to do that right now. They are licensed with the Texas Department of Insurance, and we may have some brokers in here. I know Sam Merchant is here, and he's on the IAPAC board, and he's very well versed and can direct you and your employees or even your loved ones for individual coverage to these places. But the exchanges will be a place where the